let's start with the first presentation, and for each presentation, time of 4 minutes has been allotted. Okay.
Is it conversion of non-ischemic CRVO to an ischemic variant? The objective of this presentation is whether we can differentiate between conversion of non-ischemic to the ischemic variant from the recurrence of CRVO. Now it's a case of a 72-year-old housewife who presented to us with sudden onset diminution of vision since the same day morning. She was diabetic and hypertensive since past 20 years. The right eye, she had a visual acuity of 20 by 25 and she was pseudophakic. Now when we see the posterior segment of the eye, we can see that there is dilated tortuous veins with dark column of blood. What is more visible over here is we can see that there is presence of dot and blot hemorrhages that are all over the fundus. When we see closely at the posterior pole, there is presence of multiple superficial hemorrhages also. However, the OCT showed no macular edema, so at this visit the patient was advised to observe. The left eye also had presence of dry age-related macular degeneration changes. The left eye remained normal throughout the course of visit, so I'll be discussing the right eye in the subsequent slides. So we requested systemic investigations, in which we found that she had deranged serum homocysteine levels as well as elevated triglycerides. So at this moment of time, she had presented after 1 month. Here we can see that when we compare to the presentation, there is increase in the numbers of superficial hemorrhages that we are noted. The vision also has decreased, and the OCT, if we see over here, there is presence of macular edema that was not there before. So at this moment of time, we decided that we'll go ahead and inject intravitreal bevacizumab. Over the period of time, she did improve. She was lost to follow for 2 months. She came after third month. In the meantime, she underwent coronary angioplasty, which was 1 month prior. At this visit, we can, however, see that the superficial hemorrhages that were noted before are resolving, and the macular edema has resolved. Over the period of the next 9 months, she received multiple injections, and to our surprise, again at the 9th month follow-up, the visual acuity, which was maintaining somewhere close to 20 by 25 parts, had dropped to 20 by 100. Another thing which I'd like to draw your attention upon is the superficial hemorrhages that were resolving before have now again come back, and the macular edema had also come back. We did give an intravitreal injection again, but this brought us to a diagnostic dilemma that are we dealing, the number of hemorrhages have increased which were resolved before, the macular edema which was responding to a treatment has come back again. So whether are we dealing with a conversion of a non-ischemic variant of a CRVO to an ischemic variant, or there is a recurrence of non-ischemic CRVO. Now this brings me to the objective of my presentation, that can we differentiate this conversion of non-ischemic to ischemic variant from the recurrence of a CRVO? The answer is yes, we can. Now in literature it has been said that if we want to term a CRVO as a recurrent, there has to be a complete resolution of prior event of a retinal vein occlusion, and then there should be reappearance of signs of CRVO. Now, however, in our case, we had seen that the superficial hemorrhages did resolve, but not all the signs of CRVO had gone away. So this rules out a recurrent non-ischemic variant, recurrence of a CRVO in our patient. Now the next thought what we are left with, that either we are dealing with a patient who was non-ischemic to present with, and is he converting into ischemic variant. So in literature it has been known to show that the increasing in number of hemorrhages that are there over the course of periods and over the course of a treatment, this may be a sign of progression of a non-ischemic variant to an ischemic variant. So now let's come back to our case and gaze at the response of what we get after treatment. Over the course of time, we can see that those superficial hemorrhages as well as the dot and blot hemorrhages have resolved, are resolving over the course of time, and the macular edema is also resolving, and the visual acuity is coming back to 20 by 30. Now if we see and the traditionally described clinical parameters to say it as an ischemic variant of CRVO, our case doesn't fit into the very same also. So it is neither a conversion of non-ischemic CRVO to an ischemic variant, it is neither a recurrent CRVO. So what it could be, with this food for thought, that whether it is just a progression of thrombus, I would like to end my presentation.
Very good case to present, and you have highlighted the points very nicely. And if you go back to the original article written on vein occlusions by Dr. Sohan Singh Hare, it's a landmark article. It shows that around 18% of the patients of non-ischemic variety can get converted into ischemic variety. So if they are getting converted into ischemic variety, which means there is a progression of thrombus only. Occlusion is increasing, and it is getting converted into ischemic variety. And recurrence is, though not very common, but then it is seen sometimes. It's more commonly seen in branch occlusions, where you have occlusion of one of the branches, and later on another branch is getting occluded. So even recurrence is seen in quite a lot of cases. That is why just concentrating only on the macular status is as important as concentrating on the other parameters like homocysteine and lipid profile and the blood pressure, avoiding nocturnal dip. Things like that have to be taken care of, so as many of these patients don't progress. Apart from that, even intraocular pressure also is a very important factor in such cases.
So one thing, if we are suspecting that it is non-ischemic converting into the ischemic, we should have done angiography also to see the perfusion areas.
Yeah, I do agree on that, that we don't have an angiogram of this patient at this moment. But at that moment also, we did have it's a thought in retrospect actually, that we have couple of cases where we are seeing that the hemorrhage have gone and they do absolutely fine in the course of 13 months, 24 months, and then again they have not completely.
Presenting a case of combined vascular occlusion. It is a 56-year-old male came to the tertiary hospital with chief complaints of diminution of vision in the right eye since one day. Diminution was sudden onset, gradually increasing with mild pain. Patient was known hypertensive and on medication. He is a known alcoholic and a smoker. There was no history of trauma, no past history of similar complaint, and patient blood pressure was 183 by 99. It was the only first finding regarding the history. And the vision acuity in the presenting visual acuity, BCA was 6 by 24 on the right eye, left eye 6 by 6. Near vision was N36. Intraocular pressure was 16 millimeters mercury in the right eye. Anti-segment was apparent normal within normal limits. On fundus examination, the coverage ratio in the right eye was normal with but mild disc hyperemia present. Multiple superficial hemorrhages are present with splinter hemorrhages below the disc and near in the infratemporal area. Whitening of the retina present between the disc and macula involving the fovea. In the autofluorescence, there are few spots of blocked fluorescence. On the fundus examination of the left eye, it was apparent normal. Clinical diagnosis made as both a refractive error with right eye, both artery and vein occlusion with macular edema. We sort of investigations of Schweitzer Society, routine blood investigations, carotid Doppler and 2D echography. On the right eye, Schweitzer Society round up with subretinal edema with abnormal foveal contour with subretinal edema with central macular thickness of 574. We can see the paradiscal space, the edema is also present paradiscal areas. In the left eye, the OCT was normal. Plan of care. So we planned AC paracensis of the right eye. If it is not resolving, we planned also for the anti-VEGF in the right eye. Topical NSAID was given 3 times a day in the right eye, and the first of all, the urgent physician reference in under emergency basis because of the hypertension. Abstinence of smoking and alcohol also advised. On treatment, we have done the AC paracensis right eye under topical anesthesia on the same sitting when he presented to the OPD, and referred for the physician. After 5 days, we examine the patient, and patient is not symptomatically better, so we plan for anti-VEGF also. After 1 month of follow-up, patient improved to 6 parts for the distance and near N6. Fundus photograph shows few hemorrhages with complete resolution of whitening of retina, and sepsis OCT shows the resolution of macular edema. This is a post-intervention of clinical fundus puncture and fundus autofluorescence. But the venous tortuosity was decreased. There is no macular edema. There is no whitening of the retina between the fovea and disc, but a few hemorrhages present below the disc and inferotemporal area. In the OCT, the subretinal fluid was resolved totally. The Doppler report was there is mild heterogeneous in the left carotid vessels, fibroplatic plaques in the bilateral carotid bulbs causing the stenosis as described in the carotid Doppler. 2D echography was also done. It was apparent normal. Discussion. Systemic conditions like diabetes, hypertension, uncontrolled diabetes, hypertension, dyslipidemia, and hypercoagulable disorders like antiphospholipid syndrome and protein C deficiency can cause this condition. Emboli, when there is a artery occlusion, there can be two chances. Either see a artery occlusion which is causing the vein by giving back pressure to the veins, and sometimes vein occlusion cause artery occlusion also. As the vein occludes, the increases the intraluminal pressure in the retinal capillary bed, and the pressure is transmitted to the retinal artery. And ciliary retinal artery occlusion also, it is a ciliary retinal occlusion can happen, which is 5% of all retinal-vascular occlusions. Concomitant CRVO is seen in 40% of ciliary retinal artery occlusion, and ciliary retinal occlusion vice versa is seen in only 5% of CRVO cases. Thank you.
Why not it is cilioretinal artery occlusion?
It can be, but as we didn't do fundus fluorescence angiography because there is hypertension, so we cannot say that it can be also CRVO occlusion, and the chances of and BRAO also present. But based upon the anatomical location, it can be the ciliary artery occlusion because it is we can evident it is occlusion ciliary retinal artery itself present in 15% of total population, so we are not sure of.
Welcome, sir. He's a very interesting case. I would ask you to show the photograph, fundus photograph. He is presenting a case of combined central retinal artery occlusion with vein. Rudvij, be ready with your presentation.
This is a 56-year-old male, sir, came with diminution of vision for last 2 days history. 1 day history. He has a blood pressure of 188/99, and in the there is a tortuosity present in the when we compare to the left eye other eye picture. It is venous of tortuous, and a few hemorrhages are present around the blood vessels, and there is a splinter hemorrhage below the disc. And there is whitening of retina between the area of
arterial component is very evident.
Yes, sir.
Show the OCT.
This is the OCT. The subretinal fluid is the macula and around the disc also.
But arterial component, you see, normally there is a thickening of the
Retina vessels.
So
Layers.
This is very interesting because your section of the OCT is not going to the ischemic area.
Yes.
If it was going to the ischemic
Yeah,
area,
it is
the
lower
nerve
down.
the whole layers would have been more opaque, and edema is another part, and it looks more like a venous stasis, like non-ischemic type of central retinal vein, early central retinal
So
vein
what do you do
occlusion.
ultimately?
Sir, I did a AC paralysis in the same sitting, and after control of blood pressure, I have injected anti-VEGF, and after 1 month,
Vision improved from?
vision from 624 to 66. There are few hemorrhages post intervention, and OCT was not.
This is an excellent this thing, but I have very severe, very obvious patients of both CRA, CRVO, BRA, CRVO, all this possible I have, and they're very obvious. So whenever you have widening of retina along with tortury, you have to suspect a combined.
And in this case, you'll also you can also do a fields if you, because this won't go into central retinal artery occlusion obviously, but if you have a suspicion, this is a ciliaretinal artery occlusion.
This is a ciliary.
Yes, sir.
Very good.
Nice case. Rudvich is going to
the role of anti-VEGF is not very well established, honestly speaking. If you see literature in a combined block, all of us do give for the venous component of it,
Yes, sir.
not for the arterial
Arterial.
component.
So Rudvij is going to present a case, curious case of collaterals.
I'm sorry, but I guess so the boxes are not very well arranged. I guess the PPT from one computer to another. Sorry for that. So I'll be presenting a case of curious case of collaterals. Just to give you a background, what are collaterals, and in BRVO, where do they originate from and when do they form? So they are nothing but vascular structures that develop from the existing vascular beds. They originate from the capillary bed and they join the obstructed and the non-obstructed vessels. There are three types of collaterals: arterioarterial, arteriovenous, and veno-venular. In BRVO, the collaterals are of veno-venular type, and they generally take from anywhere from several weeks or 6 to 24 months. Now, on clinical evaluation, they appear as tortuous vascular channels which link a blocked vessel with a patent vessel, as we can see over here. And they generally lie in adjacent avascular bed. With this background, I'd like to present a case of a 69-year-old female who just presented to us with a general checkup for a general checkup. She had history of hypertension 10 years back and also had a history of stroke for which an MRI was done. She was a diagnosed case of an optic disc pallor in both eyes since 3 years prior. Now when we see the right eye, the anterior segment had an NS1 grade of cataract. The visual acuity was 20 by 20 and 6. We can see over here that there is some amount of diffuse disc pallor that is noted, and if we see at the arteriovenous crossing, we do see some AV crossing changes. Now when we come to the left eye, we can see over here is there is an optic disc pallor that is noted over here, and if you can see that there are dot and blot hemorrhages which are radiating toward the first AV crossing, suggestive of a branched retinal vein occlusion. But at this moment of time, there was no macular edema. There was the vision was also 20 by 20, and the patient had just come for a general checkup. The patient was requested for systemic evaluation and to review after 2 weeks, and was explained that if in case of there is drop in vision, she would require an anti-VEGF injections. So on 2-week follow-up, we can see that the visual acuity at this moment of time had dropped from 20/20 to 20/30 parts. We can see over here that the number of blot hemorrhages and dot hemorrhages which were there have increased from the last time. And as discussed with the patient prior, she was advised to undergo an intravitreal anti-VEGF injections. No, we had she had actually she had elsewhere consulted in the interim, and she had like a paper of an OCT, so we did not request it in our institute again at that moment, but there was an OCT available at that time. During the course of time, she came many a times to us. In the interim, there were increase in the superficial hemorrhages. There was increase in the dot and blot hemorrhages. As we can see over here, also there the vessel which was patent before has now becoming to sclerosed, and there was presence of macular edema also. Over the course of next 13 months, the macular edema came in and went off with injections. She was appropriately treated for the very same with intravitreal anti-VEGF injections, and she maintained a vision of 20 by 25. To our surprise, on the 26th month visit, an inferotemporal branch retinal vein, which was diagnosed prior, had presented with presence of an superior hard exudates in our patient at the 26 months of follow-up. And we do notice, if we see the fundus photograph, the prior vessel, which was over here, is now going right up to the superior arcade, crossing the horizontal midline and joining to the above vessels. If we see, there are two such collaterals that are there, and beyond these collaterals, the vein has sclerosed. There was presence of some chronic macular edema seen as the horizontal cyst diameter was more than the vertical cyst diameter. So we had a query in our mind that are these collaterals decompensating to the superior half of the retina and causing a back transfer of the increased venous pressure that we know. To confirm that, and also we thought that whether it is presence of just microaneurysms. So we go ahead and went and fluorescein for this patient, and as we can see over the course of time, we see over here, these are the collateral vessels that they are joining over here in the superficial plexus that we are noting, one over here, one over here, and one over here. But we do see some amount of microaneurysms in and around this, and if we comment on the foveal avascular zone, it is distorted in the inferior, close to 120 degrees. Over the course of later some period, we can see that both the microvascular abnormalities from the collaterals as well as the microaneurysms both are leaking at this point. And if we notice that inferotemporal vein beyond the collateral vessel has completely sclerosed, which is evident in the fundus photograph over here. At this moment of time, seeing the OCT characteristic of a chronic cyst and a macular ischemia as seen on our fluorescein angiogram, the patient was observed at this moment. But this raised up very few questions in our mind, that why are these vascular changes in the superior quadrant beyond the horizontal raphe? So it has been shown that collaterals do cross the midline. They generally do not respect the horizontal raphe as compared to a normal retinal vasculature. Another question that popped up was, does these changes reflect the decompensation? However, I could not get an answer in the literature for the very same. And if we see over here, beyond the area of microvascular abnormalities, why are these changes in and around this area where there are no microvascular collaterals? So just a final slide. Here the OCTA helps us. It is known that the collaterals are more present in the deeper vascular plexuses than the superficial vascular plexus, and an angiogram having its inherent, I would say, some limitation in visualizing the deeper capillary plexuses, and OCTA helps us in this. So to summarize, collaterals can originate from the existing capillary vascular bed. They are of three types: venovenular, arterioarteriolar, and arteriovenous, and they are vascular channels that do not leak on FFA, and they can be present in all capillary plexuses but are most abundant in the deeper capillary plexuses. So an OCTA will help us prognosticate these patients, and probably this patient went on to undergo a laser to an avascular retina away from the collaterals, just not to decompensate the superior half also. Thank you.
It was a really very nice, in fact, a very nice picture. I was just wanting, and you answered in the last slide itself, that presence of so much of CNP areas does call for ablating these areas, because you can't watch all the, otherwise,
Yes.
increased VEGF load and they can cause. But these collaterals are known to cross the horizontal raphe,
Yes.
and they are friendly vessels. We should not we should laser beyond these vessels, because they are all friendly vessels.
And actually, there is an indication of doing laser in such cases. So much of capillary non-perfusion, so So CRVO study, BRVO study states that you should do a prophylactic laser in such cases, not for macular edema to prevent. Those are all at the junction of vascular and avascular retina. They are all budding neovascularizations. Okay. Your anti-VEGFs are preventing them from growing, but if you don't give anti-VEGF for a long period of time, they might start becoming new vessels. Thank you. We'll now invite Akshi Sharma. Spontaneous branch retinal artery occlusion secondary to retinal artery macroaneurysm.
Good evening, everyone. So I'll be starting the next case presentation of branch retinal artery occlusion secondary to retinal artery macroaneurysm. So before starting the case, the RAMs are round of fusiform dilatation within first 3 branches of retinal artery, which is usually found in women in third decades and are associated with hypertension, atherosclerosis or hyperlipidemia. And there have been very few reports of branch retinal artery occlusion secondary to RAM. So with this, I would like to start the case to diagnose and understand the association of branch retinal artery occlusion secondary to RAM. So a 70-year-old male from Visakhapatnam, Andhra Pradesh presented with chief complaints of right eye painless blurring of vision since morning. He was a known case of coronary artery disease since 7 years and was using tab EcoSprint for the same. So on ocular examination, his best corrected visual acuity in both the eyes was 20/20. He was pseudophakic in both the eyes with an IOP of 16 millimeters mercury on GAT. So on posterior segment evaluation in the right eye, as we can appreciate, the media is clear. The disc margins are well defined and with a cup disc ratio of 0.3:1, and there is retinal whitening along the superior vascular arcade, and also there is a dot hemorrhage inferotemporal to the fovea. And if you look closely, there is an orangish lesion superior to the optic disc at the level of the retinal arteriole, which is suggestive of a retinal artery macroaneurysm. The left eye posterior segment examination was unremarkable. On FFA, as we can see that there is delayed arterial filling in the superotemporal side, and there is also a hyperfluorescent lesion superior to the disc, which is increasing in size and intensity, suggestive of leakage, while the left eye FFA was normal. And in the vertical line scan OCT of the right eye, we can see that there is increased retinal thickening, and also there is increased choroidal thickness as well. While in the left eye vertical and horizontal scan, the OCT finding was normal. And also in the hemi visual field test of 24-2, it shows there is presence of inferior visual field loss, while the left eye hemi visual field was normal. So the BP of the patient was checked and was found out to be 160/80. So with this, a diagnosis of both eyes pseudophakia with right eye branch retinal artery occlusion secondary to RAM was made, and a cardiologist consult was done when the patient was started on antihypertensives along with anticoagulants, and along with this, right eye drop timolol was also started for the patient. So after 1 month, the visual acuity was 20/40 to 20/20 parts in the right eye, and there was resolution of the retinal whitening in the right eye. And the FFA also showed normal arterial filling in the superior arcade, and also the resolution of the RAM, as can be appreciated. And also in the line scan, vertical line scan, as we can see in the vertical line scan, there is retinal artery, there is retinal thinning. So with this, I would like to conclude that BRA occur to secondary to the thrombotic course of RAM in our case, and it is highly necessary to get delayed cardiovascular assessment, as RAM is associated commonly with systemic hypertension and atherosclerosis. Thank you.
Just put on the last slide. Last week. Thank you.
Okay.
So what do you think if I say it is RAM plus BRA?
But
Can
the
you say it is RAM plus BRA, or you have to say RAM secondary to BRA secondary to RAM?
It can be because BP was raised, so it is RAM with BRO. And why, if there was a leaking macroaneurysm and you are suspecting that it is causing the BRO, why it was not lasered?
it was not,
It will not resolve spontaneously.
because we were looking for the natural course of the RAM, like the thrombotic and the fibrotic and the resolving stage of the RAM. So we had called the patient after 1 month to look for the progression, like how will it respond. So that is why.
Can spontaneously is thrombosed, that's okay. All ramps need not be lasered.
Yes, sir. But if they are suspecting that this arterial
But her
occlusion
main
is
finding was whitening,
whitening.
whitening of the upper
Yes.
control retina.
Can you go back to the first angiogram?
It shows delayed filling of the whatever it was. No, I think I agree with her that there's no need of any treatment in this. There's no need of any laser in this kind of.
Yeah.
It's a
I
very
can-
interesting case and very well documented.
Can
Also.
we call this RAM plus BRO or RAM BRO secondary to RAM?
There have been like
Can concurrently occur, no?
both can concurrently occur, but
So how is your reaction if I say this patient has RAM plus BRO?
that can also occur. But the RAM that is there, that is causing an occlusive effect over the arteriole and leading to the BRO occurrence.
So in any case, I don't know. RAM structurally is a structure. Does it disappear like you've shown? RAM disappears.
It usually takes 3 to 4 months for the RAM to spontaneously regress, but in this case it regressed within 1 month as we called the patient, so that was unusual in this case.
How can we differentiate from plaque and Raman plaque? It can be the plaque might be causing the BRM.
The blown up the picture there, where the microaneurysm, macroaneurysm is there. It's very interesting. It can coexist. Can you blow?
Uh, if
FA?
it-
FA? Actually see that the aneurysm is not filling up. See that? It's already thrombosed. The thrombus is already, or the whatever is in there is already there. So that itself might be causing a retinal artery occlusion. So branch artery occlusion.
yes, sir.
Very good angiogram. Very nice.
Very nice. Very nice case.
Can I just have one comment? Can that be a venous macroaneurysm also causing an adjacent thing? And just to point an answer for a laser too close to the disc, and for BRAO, if we're going to laser on an artery, probably it will itself lead to a BRAO. So probably we would not have done a BRAO. And just a question over here: can this be a venous?
Venous aneurysm will not have
This become
close the
a-
artery.
Close the artery.
That can't close the
That
artery.
cannot close the artery. The artery has a more resilient wall as compared to the vein, so it cannot compress things.
Just because the artery occlusion was there, so we were suspecting, like just prophylactically we started the patient on anti-glaucoma medication.
The fovea is very nice, and even if you had treated the macroaneurysm by anything, the vision would have been the same.
No, actually, I agree with him that I don't think so in a patient who has improved the vision, prophylactically use of Bozox or but all of us do give in patients who have CR.
Maria,
BRAO
can you come
is
in?
six vision.
Yes, sir, I agree with that.
Questioners like retinopathy in a case of acute pancreatitis.
Good afternoon. Today I'll be presenting a pusher-like retinopathy in a case of acute pancreatitis. A 14-year-old girl came with the complaints of abdominal pain, recurrent episodes on and off for the past 5 years, which was dull aching, increasing in severity for the past 3 days, vomiting for the past 2 days, which is non-projectile, associated with diminution of vision in both the eyes for the past 1 day. Even though the patient had abdominal pain on and off for the past 5 years, this episode was accompanied with a diminution of vision for the past 1 day, which was sudden in onset, painless and progressive in nature. Past history: patient gives a known case of pancreatitis, had recurrent episodes over 1 year back. Documents showed that MRCP done in the previous episodes revealed pancreatic divisium with pancreatitis and features suggestive of the same. Personal history: consumes mixed diet, normal bowel and bladder habits, and normal sleep pattern. General examination of the patient revealed icterus, otherwise pulse rate and blood pressure was normal. Systemic examination: per abdominal examination showed a mild tenderness noted in the epigastric region, no guarding. Cardiovascular system, respiratory system and CNS was not remarkable. Ocular examination of the right eye showed a best corrected visual acuity of 1/60 and left eye showed 3/60. Otherwise, ocular examination was normal. Fundus examination in both the eyes showed disc pink in color, vertically oval, and elevation of the disc over the temporal edge, and vessels arising from the center of the disc branching dichotomously, and background retina in both the eyes showed multiple cottonwool spots surrounding the disc. Routine investigations were done, and the patient revealed that the serum amylase and lipase found to be elevated, suggestive of acute and chronic pancreatitis. And OCT showed elevation of the perifoveolar region. Noted edema has been noted in the inner retinal layers between the disc and the macula, which was more pronounced in the right eye than in the left eye. Patient was subjected to a routine USG abdomen followed by MR cholangiopancreatography, for which the features were suggestive of the same acute pancreatitis. Treatment was started by the surgical gastroenterologist for acute pancreatitis, and patient was also started on injection IV methylprednisolone 35 mg per kg per day for 3 days, followed by tablet prednisolone for 11 days, nepafinac eye drops and tablet acetazolamide. The patient's visual acuity was routinely checked up, and on the day 12 of steroids, the patient's visual acuity improved in the right eye to 612 partial and in the left eye to 612. A fundus re-evaluation showed resolution of the disc edema and also the clearance of the cottonwool spots and the edema in both the eyes. Discussion: Pusher retinopathy is described as a chorioretinopathy associated with any indirect trauma or non-ocular injury, whereas any typical retinal findings occurring in the absence of trauma, it is referred to as Pusher-like retinopathy. The most common clinical symptom is always diminished visual acuity. The most frequently encountered fundoscopic signs were cottonwool spots and noted in 93% of the cases. Diagnosis is made if at least 3 out of 5 criteria present, namely Pusher flecken, retinal hemorrhages, cottonwool spots confined to the posterior pole, probable explanatory etiology, and complementary investigations compatible with diagnosis. Possible pathogenesis: the elevated pancreatic and lipases will stimulate the complementary system, and which causes leukocyte aggregations, which can cause an emboli and microvascular infarct of the retinal nerve fiber layer. Treatment literature also supports a high dose intravenous steroids in improving the visual acuity, which prevents the granulocyte aggregation and complement activation and partial recovery of the neuronal fibers. These are my references. Thank you. Fundus picture on the day of presentation, and the fundus picture a repeat OCT has been taken, sir. This is the fundus picture, sir.
So I think pancreatitis, the basic problem I think is what we call leucoembolism or fat embolism. That causes the arterial block in
Yes,
such
sir.
patients.
Yes, sir.
And not a very common disease, honestly speaking. We have seen a lot of pancreatitis, but I think you treated with IV methylprednisolone.
Yes, sir.
But there have been reports about intravitreal steroids also. Have you seen that?
Yes, sir. Certain reports suggest of intravitreal steroids, and also there was one of the case report where a patient with acute pancreatitis presented with both acute renal cortical necrosis and Pusher-like retinopathy, and visual acuity and the inflammation improved with IV methylprednisolone as well.
Quite controversial. You see, if you see literature to roll, so it's very, very controversial. But I agree with you that we have to, be on the defensive side primarily to save the
Visual acuity.
Yeah. And most of the case reports do say IVMP does help. But there have been reports about intravitreal drug therapy also. Good contribution.
Role of acetazolamide?
Because the patient had edema, in order to prevent any further edema in the macular region, and we were started on acetazolamide, ma'am, because on the second day and the third day the macular reflex was dull and we noted some edema in the macular region. That's why we start.
Secondary to the disease person.
Yeah.
Over usage of acetazolamide or Dorzox or such things aim is to pump have the more pumping action of RPE.
We should be careful in systemic conditions like
Good case.
Thank you.
I think the purpose of these case presentations is very well received in midterm conferences, because when we started midterm conference, we thought we will not have any national symposiums, we will not have any instruction courses, we will just have case presentations and some talks, rather than the routine of all these things which we do in annual conferences. Very happy to see all these cases.
So next speaker, Dr. Hiteshi Jain. Yeah, she'll be speaking on an atypical case of atypical CSCR.
Yes.
Atypical case of atypical CSCR.
Good evening, everyone. I'm Dr. Hiteshi, and I will be talking about an atypical case of atypical CSCR. So we had a 50-year-old hypertensive and diabetic gentleman who complained of painless loss of vision for 3 weeks. He had a vague history of joint pain for which he was taking homeopathic medication, and he was a teacher by profession, and he claimed that he was under considerable professional stress. On examination, the vision in his right eye was hand movements, the anterior segment was normal, the IOP was normal, the EOMS were full and free, and the left eye visual acuity was 6/18, and the rest of the anterior segment examination was completely normal. On fundus examination, this was the picture we saw. In the right eye, there was exudative RD, which was mainly inferiorly involving the macula as well, and there were multiple subretinal yellowish lesions. In the inferonasal quadrant, there was also an area of vascular sheathing with 2 hemorrhages next to the sheathing. The left eye showed subretinal yellowish lesions mainly concentrated at the posterior pole, but there was no exudative RD as such. The OCT on day 1 of presentation showed a lot of massive subretinal hyperreflective material and neurosensory detachment. In the left eye, also there were some areas of RP alteration and subretinal hyperreflective material. An FFA was performed. So this is the FFA of the right eye, which shows early pinpoint hyperfluorescence, which increased as the FFA progressed, and the intensity and the size increased. In fact, if you see nasal to the disc, you can also see a kind of a smokestack appearance. The left eye also, although not as much as the right, showed pinpoint areas of hyperfluorescence increasing in intensity and size. So taking into consideration the history of the patient, that he was on homeopathic medication, he was under stress, and he was a hypertensive, looking at the clinical picture of extensive subretinal fibrin, diagnosis of atypical CSR was made. His routine lab for uveitis was also performed, and serum 8 AM cortisol was also done. Serum potassium was done, which was all within normal limits. He was asked to stop all homeopathic medications. Focal laser to the points of leakage was done, and tablet eprenone 50 milligrams once a day for 2 weeks was started. So you can see the follow-up of this patient. This is the second picture is at 2 weeks of starting eprenone and post laser. You can actually see the well-defined track of subretinal fibrin, which is tracking downwards, and at 4 weeks that fibrin has almost become just a linear structure, and there is no RD at this point. So the above 2 images are of the right eye. You can see the subretinal material at the fovea, which resolves at 4 weeks with minimal fluid, and in the left eye, it has completely resolved. So these are my references, and I had 2 questions to the panel, like if I may. what would you have done in this particular case? And in cases of atypical CSR or CSR in general, how long do we continue eplerenone?
One thing, if you are suspecting the stress and the homeopathic medicine, usually it is seen that we have seen some cases, if you stop the causative factor, there is no need of any other treatment in such cases.
Okay, even in such chronic looking
Yes, but
CSR
at
cases.
least you can wait,
Okay.
because we have seen few cases that if you stop the like patients on this hormonal therapies or steroids in any form, if you stop, they improve.
Okay. Ma'am, in this case, he had given a very vague history of taking homeopathic medication a month back, so there was nothing really to stop at that point. That's why we did this.
Usually, we give eplerenone around 3 months, but you will get serum potassium levels at 1 month and review the patient. So this is what given chronic CSC patients usually.
BCVA, you didn't tell what happened to BCVA in the
Yeah,
right eye.
sorry, I did not mention that. So the BCV of the right eye became finger counting 1 meter. The left eye was maintained at 618. It didn't improve the VC.
So now come back to the last. The only thing I would have done is I would not have started eplerenone actually.
Okay.
I would have stopped the causative factor and laser, because laser, I have a lot of pictures where this fibrin has melted and patient has dramatically improved from say FC or finger counting to 612, 69 also. But I am happy that your documentation is very good, but you keep it under follow-up. This patient will likely improve more also, should improve more, because the track center picture is much better than the third picture in fact. And most of these patients do pretty well either with laser, because if you do both of them, you don't know
which one
what is working where. So I would have actually, do you have any laser photographs? You see, you should show one FA where you show the laser marks.
Okay.
So that
I
will
don't have that
increase
right
our
now.
confidence. Where
Yeah.
have you must have lasered that smokestack laser.
Yes, definitely. Yes, we do.
So that should also be part of the presentation.
Okay.
Because you have just orally told that laser was done, but angiography will show that laser spots.
Yes.
But the second question was, what was the first question was?
Would you have managed this, approach this case differently?
Eplerenone we normally give in a central involving CSR. Your patient was a non-central involving leakage, so laser alone should be fine.
Okay.
Could you explain the vasculitis which you were telling?
Yes, sir. That actually was also a question. It threw me off actually, because that vasculitis with hemorrhage did not really fit into the picture.
It could be a
But
secondary CSR, because somebody may have given because of vascular steroids and maybe then developing CSR. Because
One of the patients, we have a very similar patient, and that patient has been treated massively with steroids because of suspicion of leakage.
yeah.
Because it also has a multifocal type of presentation, bilateral presentation. Usually CSR won't be a bilateral. This kind of even multifocal usually doesn't.
So that's what I was saying, because if you see vasculitis, most of us start with steroids, and then
See is the history of apart from stress, like using medication like steroids and hormonal. If you better to do laser, even if prevents recurrence also.
okay.
I think it is a typical case of chronic CS.
Okay.
It is a subretinal fibrin is present.
Okay. Thank you.
Ravi Kumar, Mr. Ravi Kumar. Yeah. He also is presenting a left eye subretinal cysticercosis.
you see your cases are over, does not mean you leave the hall.
Ravi Kumar. Ravi Kumar Bhukia. सबमिट किया था सुबह. If you want, I have now also. Yes.
Or you want to come later on?
No, sir, it's done. Good evening, one and all. I am going to present subretinal cysticercosis. So, coming to the history, a 25 years male patient presented with chief complaints of headaches for 1 month and blurring of vision in the left eye since 7 days, associated with vomiting 3 to 5 days. And the rest of the history is within normal limit. Then coming to the general physical examination and systemic examination within normal limit. On ocular examination, visual acuity is in right eye 6/6, left eye 6/9. That with anterior segment within normal limit. On fundus examination, going to the right eye within normal limit fundus examination, and left eye shows cup disc ratio is normal, that is 0.3:1, NRR pink, FR sharp, AVR 2:3. A yellowish white cystic lesion in the inferotemporal part of the left eye with pigmentary changes surrounded by the cyst. So this is the RD chart showing that yellowish white lesion in the inferotemporal quadrant of the left eye with surrounded pigmentary changes. Then coming to the fundus picture of the left eye, this is showing the posterior pole of the fundus picture of the left eye. This is showing this inferotemporal quadrant, a yellowish white lesion with overlying retina, retinal vessels with white dense opacity in the center of the cyst, that indicates that scolex like lesion. Surrounding the whitish pigmentary changes are there around the cyst. This is the posterior pole of the OCT on the same eye, that is left eye. This is the inferotemporal quadrant of the OCT, shows that hyper reflectivity of the cyst, showing the scolex and vitreous cells, then RP pigmentary changes, and with cyst wall. The diagnosis we came as left eye subretinal cysticercosis with RPE changes. Then we planned for left eye 25 gauge transconjunctival pars plana vitrectomy with cyst removal with 14% C3F. Before planning for C3 surgery, we sent to neurology opinion to rule out any neurocysticercosis, and they have identified neurocysticercosis, and they started anti-epileptic medications. That preoperative treatment has been given. That is pre-op and post-op isolone. This is a small surgical video I have here. I will show. This is transconjunctival 25 gauge pars plana vitrectomy with core vitrectomy has been done. Then triamcinolone injected and PVD induced. Then cyst is nearby the gist. When we located the light over the cyst, the scolex has been moved. This is peripheral vitrectomy has been done. Now diathermy has been used to create a small retinotomy with soft tip extrusion. We have removed that subretinal cyst into the vitreous cavity without rupturing it. Now used the high speed vitreous cutter. There is no any cyst fragments as released in the vitreous cavity, so there is less chances of any vitreous reaction in the post-op period. Then laser has been done. The post-operative period as antibiotic, topical and oral steroids has been given. Then post-operative first day vision is hand movements with gas filled eye with retina attached. The take-home message for this case presentation is proper screening of the eye before starting anti-helminthic drugs. timely management of ocular cysticercosis and neurologist opinion and family screening to be done. Done.
I'm not very sure about family screening. Rest everything is very good. Family screening, but you see, if CT scan is positive and if you start albendazole in such patients, because this cyst can die,
Yes.
and then they can excite a severe inflammatory reaction.
Yes.
You see, from eye point of view, we do not want the cyst to die in the retina or in the vitreous cavity, because if they die there, then they excite very severe inflammation. So post-op it's okay, but pre-operatively I would hesitate to start, unless you have done surgery within few days of neuro opinion. So that is one differing point which I would.
No, they didn't started they started anti-epileptic, sir.
Anti-epileptic.
Yes.
Okay, then it's okay.
Yes.
Then it's okay,
Yes.
because we have to differentiate, albendazole for muscles and all, it's
Yes,
okay.
yes, yes.
Ocular, extraocular muscles, but
Yes.
not for subretinal this thing. That's okay.
Yes.
Anti-epileptic is okay. Vision post-op was
The
okay.
6 sir. 6
Excellent.
after 3
Video was very, very good. Excellent video.
Thank you.
So the message only is that anti-epileptic CT scan is a must for all patients of cysticercosis, and if that is positive, please do not start albendazole, and that can be done post-operatively but not pre-operatively.
Yes.
But for extraocular muscles and other locations,
We
it is
can
okay.
start
Yeah.
anti-epileptics. Yes.
Very nice,
Thank
very
you.
nice.
Thank you.
So the next speaker is Dr. Megha Gulati. Dr. Megha, she is speaking on a curious case of recalcitrant focal endogenous endophthalmitis.
Good evening all. So here I will be dealing a case of endogenous endophthalmitis that was recalcitrant. So a case of endogenous endophthalmitis that was recalcitrant to our conventional management therapy. So 59-year-old male hailing from West Godavari, Andhra Pradesh, presented to us with left eye diminution of vision since 2 weeks. Now right eye ocular examination was unremarkable apart from grade 2 nuclear sclerosis. Left eye he had a visual acuity of 20/50. There was grade 2 nuclear sclerosis. In anterior chamber there was inflammatory reaction of cells 3+ along with the cells in the anterior vitreous phase. Now fundus examination showed grade 2 vitritis. We can see disc and the retina very hazily, and in the nasal quadrant you can see this small whitish pearl-like thing, that is string of pearls as marked by the dots. Now the periphery examination of same patient showed a 1.5 disc diameter yellowish fluffy necrotizing retinitis lesion. It's having ill-defined margins. It's there in the superior nasal quadrant. And the main characteristic of this lesion was it was growing and extending into the vitreous. So when we saw clinically, we could appreciate that it is coming into the vitreous cavity and not just confined to the retina. The same was confirmed by the OCT line scan. Here you can see that the hyperreflective lesion is protruding from the retina into the vitreous. Now on asking positive history, he had a gastric outlet obstruction recently, for which he underwent a distal gastrectomy, jejunostomy and jejunojejunectomy 2 weeks prior to when he presented to us. And for this he underwent a gastrointestinal surgery. The mass was excised and was diagnosed to be a poorly differentiated adenocarcinoma of stomach. Now during his admission, he didn't had any signs of sepsis. There was no fever. Now we were dealing with a case of vitritis with retinitis with a history of 2 weeks prior gastrointestinal surgery, for which central line was also secured. So likely we were dealing with a case of left eye endogenous endophthalmitis. Now whenever we see a case of endophthalmitis endogenous in origin, we have to ask 3 questions, whether it is focal or diffuse. So in our case there was no doubt because we could see a focal retinitis lesion. So it's a focal endogenous endophthalmitis. Now what is the likely etiological cause of this endogenous endophthalmitis? Now there are many clues on clinical examination itself which give us the answer. It had a string of pearls appearance. There was a focal retinitis which were growing into the vitreous, so a rain cloud sign on OCT could be seen, and there is a history of prior gastrointestinal surgery. So likely the cause is fungal, that is Candida endogenous endophthalmitis. Now we have to identify the systemic source of infection also, but the blood culture and urine culture were negative. So there was both eye senile cataract with left eye focal endogenous endophthalmitis and endophthalmitis with the likely etiology Candida. We went ahead with left eye posterior vitreous biopsy because the lesion was quite in the periphery. Over the retinitis lesion, we did the posterior vit biopsy and injected intravitreal antibiotic. Although a strong suspicion of Candida was there, but still we injected antibacterial along with antifungal. Now, because of the strong suspicion of Candida, we started the patient on oral fluconazole 200 milligram. Vitreous biopsy didn't show any organisms on smear and didn't show any growth on culture also. After 3 days, we could see that the retinitis lesion is increasing in size, vitritis has also increased, and the vision has dropped from 20 to 50 to counting finger close to face. So, we shifted the patient from tablet fluconazole to tablet posaconazole. Now, posaconazole has stronger affinity for the target and it is known to work for the mutant strains also. And its efflux is very slow. So, when all the drugs are already eradicated, this drug is still active comparison to fluconazole and voriconazole. So we shifted the patient from fluconazole to posaconazole and we planned for a pars plana vitrectomy with repeat intravitreal antibiotic injections along with antifungals. Now, despite 4 intravitreal antibiotics and antifungals, the lesion was not responding, vitritis was increasing and the lesion was status quo. So what next? We were dealing with a case of recalcitrant endogenous endophthalmitis and vitreous biopsy also didn't help us in this case. So we planned for a silicone oil injection. Now silicone oil injection has a bactericidal and a fungistatic property. So it was going to help in both the cases. So we went ahead with silicone oil injection. Now patient, because of the cost factor, since posaconazole is quite costly, we shifted the patient back to fluconazole. And patient was also started on the first cycle of chemotherapy for his adenocarcinoma of the stomach. Now after 1 week of this presentation, we could see that the lesion has quite increased in size. And as it is an oil-filled eye, there was no increase in vitritis. But the lesion, you can see on OCT also, it's a double bump can be seen. So what could be the cause for the increase in size of the retinitis? Either it could be that we shifted the patient back to fluconazole, or it could be that after the patient was started on chemotherapy, the fungus started to proliferate more. But now nothing can be done, we can't stop chemotherapy. After giving all the intravitreal antibiotics, systemic antifungals, pars plana vitrectomy and silicone oil injection, then also the lesion was not responding. So what next? We went ahead and did cryotherapy to the retinitis lesion because this retinitis lesion was in the periphery. So double freeze thaw technique of scleral cryotherapy was done. There were 3 sittings of cryotherapy done. Firstly to the nasal margin of the lesion and to the surrounding retina, then to the temporal margin and then to the center of the retinitis lesion. And here we can beautifully see that the retinitis lesion has completely resolved and there is no recurrence post cryotherapy. Now this is the timeline showing that retinitis lesion, which was increasing despite antifungal antibiotics, oral as well as intravitreal, pars plana vitrectomy and silicone oil injection could not help. Then cryotherapy acted as a last resort and helped us in resolution of the retinitis. So there were 3 learning points from this case. If there is a retinitis foci which is growing progressively into the vitreous and there is a history of gastrointestinal surgery, likely causes Candida for that endogenous endophthalmitis. Silicone oil injection in cases of endophthalmitis, it has a bactericidal and a fungistatic effect. So the studies have shown that the strains of bacteria responsible for infective endophthalmitis, they fail to survive in silicone oil for longer than 3 days, but fungi can still persist. This could have happened in our case. And cryotherapy can be used as an adjunct in recalcitrant endophthalmitis in absence of favorable response to conventional therapy, as happened in our case. Thank you.
Very nice documentation again.
Thank you, sir.
Fungal focal endophthalmitis actually is well documented after any gastrointestinal surgery.
Yes,
I also have multiple patients like this. The only difference I have done is that, personally speaking, on the look of it, clinical picture to me does not look like Candida.
Okay.
It looks more, because Candida lesions are slightly whitish in color and they are slightly smaller compared to a big granuloma. This is yellowish looking lesion. Normally Candida will be whitish, and whatsoever I have seen is part candida lesions and slightly whitish fluffy kind of lesion.
This was fluffy to start with,
Yeah.
but that
The
it was
color
protruding
I
into
am saying,
only the
because
color.
I pay a lot of importance to color also. But I think cryo, you have done an excellent job. Only thing I would have done differently is that you see amphotericin repeated injections are required even in silicone filled eyes.
Yeah, we did that.
Yeah,
We did that.
repeated injections.
So when we were doing cryotherapy, along with that also we
Yeah.
were injecting the
Well
antibiotic and
managed.
antifungal.
See, I have one patient only where ultimately we also, you see that patient of mine, he was a medical student actually, and his vision was 6/6, and but that you know, in the upper temporal part this was not going away. So ultimately we did the same, and you know, cryo had to be done. You know, killing by ice basically, you know, we have
Yeah.
to. That's the only way out. Or
So this lesion was in the periphery, so we
Yeah.
could do cryo, but if it had been in the posterior pole, then cryo would
so,
not have helped.
if it was on the posterior pole, then only recourse would have been repeated
Yeah.
amphotericin
Intravitreal.
beam.
Yeah.
Yeah, you had some. Shout. Can't. Why was cryo done?
When would you repeat? He's
When
asking.
would you repeat an amphotericin be in an oil-filled eye, and how much dose?
The dosage I don't change because I don't change because a lot of people say that in a silicone filled eye you reduce the dose to half.
Basically because of volume.
No, basic aim is to, you know, kill that organism, and I don't think so. It is so retinotoxic that you know, we should half the dose. I agree with you that because silicone oil is filling the entire 4 cc of the vitreous, and only space is between the retina and the oil, so dosage required will be less. But even for vancomycin and the only dosage reduction I may have is when we used to use omecacin, but no longer we use omecacin regularly. But immediately you injected just as a cocktail of drug, or
Cocktail, yes. Because vitreous biopsy was not showing any
the biopsy
organism,
may be negative. You
Yes.
did. It was
especially in
getting
fungal cases.
culture, yeah,
Yes.
that would be, yeah. Any other point?
Sir, as it is microbiologically not proven case, can we do everything in one sitting? I mean, apart from injecting every sitting around 4 or 5 injections, can we
Everything
do,
means what do everything
three
means?
injections? I mean, vitrectomy, oil, and cryo in one sitting.
I
So
would have
that-
injected oil in the first go. Normally, you see, I am very
As in
fond of putting oil in
fungal.
most of, especially in such patients. But since I think presumably the patient had excellent vision and
Yeah, vision was good
yeah,
for the patient to
therefore,
start with.
yeah.
But after third injection, it was mounting at the first phase.
That was because of increase in vitritis. But when we injected oil and there was no vitritis, vision improved for the
But
patient.
I think there is a learning in this that in contrast to bacterial, fungi do not respond so well. Despite fluconazole, we do not use at all. We use either voriconazole or
Posaconazole.
Yeah, or amphotericin ultimately.
So after COVID came, posaconazole was
Correct.
remarkably
It goes
used.
away and then comes back again.
Yes.
Yeah, yeah.
And it will just, you know,
Yeah.
feel as if it has gone. And then suddenly after
can
some
recur.
weeks it will start growing in.
You see, I know of another patient who was an optometrist in our hospital only, and he developed and he maintained very good vision. Ultimately, you know, he went to seek another opinion where they did something, and ultimately he lost that eye. He lost that eye from 6/6 to PL negative. So I think your management is I think well, yes. RT-PCR should have been done actually. You want to defend why did you? Because they depend too much on clinical judgment.
Yeah. So clinical suspicion was strong towards fungus. So even if PCR would have come out to be negative, we would have deferred change of treatment.
But I agree
So-
with you. RT-PCR should have been ordered in such patient. Should have been ordered. Nowadays, you know that yeah,
It's a very good tool.
it's a very good tool and does help in such patients.
Because in immunocompromised patient, it's not necessarily just candida, it can be some kind of a follicular lung infection.
So any role with any role because this patient had adenocarcinoma of
Yes.
stomach also.
Yes, yes, yes.
So because of chemotherapy, further immunosuppression.
Yeah, that could have been a factor that retinitis lesion increased in
Because the
size.
lesion was not
Yeah, it
responding.
was suddenly in 1 week the retinitis lesion increased.
But a lot of take-home messages from your case. Excellent.
Thank you, sir.
So next speaker is Dr. Siddharth Madan. He will be speaking on delayed onset endophthalmitis following successfully treated acute endophthalmitis post IVR in DME.
Good evening all. After having this interesting discussion on endophthalmitis, I'll be presenting yet another case of delayed onset endophthalmitis following successfully treated acute endophthalmitis post IVR in diabetic macular edema. So this was a 60 years old lady who was a type 2 diabetic for 12 years on insulin and a hypertensive for 2 years. She presented with gradual painless progressive diminution of vision in both her eyes, right more than left, for 6 months. She was both eye pseudophakic. She had history of intravitreal ranibizumab injection in the left eye, which she had taken 1 month back for PDR with DME. Her presenting visual acuity in the right eye was 6/36. She had mixed retinopathy with DME in the right eye, which was confirmed angiographically, and the patient received intravitreal ranibizumab injection in the right eye. On day 1 following the injection, the patient developed sudden onset pain, redness and diminution on vision, and she was diagnosed as a case of acute post-operative endophthalmitis. We administered her intravitreal antibiotics, vancomycin and ceftazidime, and IV antibiotics were continued. On day 2, as the patient was progressing, the patient underwent pars plana vitrectomy. The AC tap and vitreous biopsy were sent for culture, and we performed a near total vitrectomy with a posterior hyaloid removal. The vitreous tap at this stage grew Enterococcus faecalis, which was sensitive to ceftazidime and vancomycin and was resistant to cotrimoxazole. She was managed conservatively, topical steroids, subconjunctival vancomycin. The patient eventually developed inflammatory glaucoma. She was on IV mannitol and oral Diamox, and following this, the patient had electrolyte imbalance. She had to be in medicine ward for 18 days. However, she was discharged after a gap of 18 days with a visual acuity of finger counting 3 meters. 1 month after discharge, we went ahead with PRP, and the patient was maintaining a visual acuity of finger counting 4 meters. To our surprise, the patient presented 1 month later with another episode of pain, redness and diminution of vision in the same eye. Visual acuity was hand movement close to face, and the IOP at presentation was 39 millimeters of mercury. Here we suspected it was a delayed post-operative endophthalmitis or an endogenous endophthalmitis. The etiology we thought could have been fungal, or was it a remission of the previously existing Enterococcus infection, or was there any underlying systemic source? So on the day of this presentation, we went ahead with intravitreal injection of vancomycin, ceftazidime and amphotericin B, and the topical antibiotics and antifungal were continued on an early basis. The patient continued to deteriorate on day 2. In the meantime, we went ahead with her ultrasound abdomen, CT chest, urine and blood cultures. They all turned out to be negative. Her dental opinion was done, which advised no active intervention. ENT and gynecology opinions were done as the patient had ear discharge and vaginal discharge. However, they were not contributory to the case. The patient was developing epithelial toxicity because of the early dosages of antibiotics and antifungals. So on 3rd day of presentation, the patient underwent pars plana vitrectomy with PCIOL explantation, and the capsular bag and IOL were sent for histopathology. On vitreous biopsy, we observed gram-positive rods, which were nocardia positive. They were acid-fast, however, though there was no evidence of fungus seen. To add to this, we went ahead with PCR testing, and it was confirmatory for nocardia, and this nocardia, which grew on culture, also was sensitive to linezolid and cotrimoxazole. The capsular bag showed fibrocollagenous tissue. CECT and bronchoalveolar lavage were negative for nocardia. The patient was continued on linezolid oral and cotrimoxazole for 4 weeks, and along with that 0.2% topical linezolid. The patient continued to improve. At 1 week, the cornea cleared, and at 2 weeks, at about 12 days, the patient was discharged. These are the follow-up OCTs at 1 month of follow-up. So intraocular nocardiosis, it's a very opportunistic infection. They are rare infections. They have extremely poor outcomes. The patient may need enucleation. However, the index of suspicion is very low, so it results in delay in diagnosis. The patients may present with orbital cellulitis or vitreous abscess, and these eyes require multiple surgical interventions. Predominantly, they have anterior chamber involvement, which is more than the vitreous involvement. Amikarsin used to be the drug of choice, but now, because of the toxicity, we have cheaper alternatives in the form of linezolid and cotrimoxazole, which we administered in our patient. Gold standard is PCR, so therefore we have to be wary of this organism, which can result in presentations like this, and not all cases of delayed onset endophthalmitis which require re-vitrectomy are fungal. So thank you.
What is the time duration gap between first onset and second onset?
So when first onset happened, 2 months after that, the patient presented with the episode of re-endophthalmitis. So
I think you said 1 month.
You
1 month
mentioned
after,
1 month.
no, that was after the PRP. So I would say 2 months after the first presentation, the patient again developed endophthalmitis.
So normally I would not, you see, I would not, say two diseases occurring. I would have suspected that ongoing only some lurking must have been there or inadequately treated previous, because most of the endophthalmitis we don't stop treatment after 3-4 weeks. They continue for longer time. And first growth was enteroficalis,
Yes.
which may be a contaminant somewhere, and most likely we were dealing with nocardia then and there only. Most likely, because you see, clinically, you should never think of two kind of one is acute, वो ठीक हो गया, उसके बाद फिर chronic एक और आ गया. So it may look very funny, but I would think that first enteroficalis was the contaminant, and we were dealing with nocardia, and it got suppressed because of whatever, and then it flared up very badly. And nocardia, that you are right, linezolid is 600 milligram twice a day for a pretty long time is the answer. That it generally resolves very nicely with oral linezolid. And gram-positive rod, they respond very nicely.
So the only pointer was the culture. Actually, the culture never showed, and the gram stain never showed any acid-fast organism. So that was the only thing.
I agree,
Otherwise,
because
the
we
only
sometimes either become wiser by the microbiological or become misled. But generally, clinical sense says that never suspect two kind of this thing in one. Clinical, as a clinician, I'm saying. But you are right. Whatever you have documented, very well done. An excellent collection, I must say. After a very long time, I'm seeing the first presenter also and you also. Very good documentation of day-to-day progress and what's happening. Must compliment very good presentation.
Thank you, sir.
Dr. Neha Sudhakar will present vitreous hemorrhage from an unknown cause.
The other lesson to be learned is that intravitreal injections should not be taken so lightly. You see, whether it is ranibizumab or eccentrics or whatever, should not be taken. And you see, endophthalmitis, because of this intravitreal pharmacotherapy, is more malignant than see cataract surgery also, because we are giving the inoculum right into the culture media, that is vitreous.
Good evening all. My case is a vitreous hemorrhage from an unknown cause. This is a male patient, 50-year-old. He was post-COVID 15 days. He came with sudden painless loss of vision since 3 days in left eye. He's a known diabetic who is on insulin. The right eye was 624 and the vision loss is contributory because of the posterior and anterior capsular cataract, and the left eye was counting fingers close to face, and he was pseudophakic who was operated 2 years back. Apparently it looked like a simple PDR to me, so I didn't take a fundus picture of it, thinking it's a simple PDR where we could see a NVE in the right eye in the superiotemporal quadrant, and the patient had subhyaloid hemorrhage and NVD. So we advised pan-retinal photocoagulation to the patient, and meanwhile he said he's not able to see with both the eyes clearly, so he underwent right eye cataract surgery, and the left eye we did a PRP, possible PRP, and then we gave a Avastin injection. So the right eye was still the same, and so we advised pars plana vitrectomy. The patient underwent vitrectomy and everything looked fine. His vision also improved to 612, and everything went on well. And post 1 month post surgery, patient came with diminution of vision in both the eyes, 624 and 618, and there were cells in both the eyes. Apart from that, we couldn't find any KPs in the eyes. And this is how he presented to us with serous retinal detachments and deep retinal hemorrhages in both the eyes. And in left eye, we could see disc hyperemia. Then we did an FFA, and patient had vomitings in between, so we had to stop FFA in between, and we could only take these pictures. There was an NV, and we could see lot of multifocal areas of pinpoint leakage and large placoid areas of hyperfluorescence, and there was distaining in the other eye. I took an OCT. Patient had the subretinal detachment with septae formation. Then his sugars were not under control to start him on steroids, so I asked him to come back after an endocrinology opinion, and within 2 days this is how his OCT has turned out to be. There were multiple pockets of subretinal fluid with septic. Then I thought it is sympathetic ophthalmia because he was operated in both the eyes, right eye and left eye vitrectomy. So we started him on a standard protocol, that is 1 gram IV methylprednisolone for 3 days and then oral steroids with tapering over 2 months. He was doing all good for 4 months, around 4 months, and then in November he came back to us with decreased vision in right eye and cells. He was on maintenance dose with oral steroids. So then we could see a subretinal membranous fibromembranous structure which is present in between fovea and the disc. He had developed a CNVM. So then we seek the rheumatologist opinion, thinking he should be started on an immunosuppressive, and he was started on Azeron, azathioprine 50 mg BD after ruling out the infection and other connective tissue disorders. And we concurrently injected him with ranibizumab 3 doses. So I asked him to send me a WhatsApp picture so that I could see him what the rheumatologist has told, and that is when I saw his WhatsApp picture, and there was vitiligo which was always which I didn't notice because he was always wearing a mask post-COVID. Then I asked him to send me a clear picture of how he is, and this is how I could find the vitiligo around his lips. Then I asked him if he had any signs of headache or meninges. He said he had stiffness of neck. So then I changed my very first diagnosis of PDR to a proliferative retinopathy as a feature of VKH syndrome. So we gave him 3 injections of ranibizumab, and this is how it is. And he had another episode of recurrent VH in his left eye. Then later we stepped up his immunosuppression to MMF 2000 mg, and he was already on Azeron and Vicelone. Then we saw a recurrent episode of anterior granulomatous uveitis. Then he was then stepped on to biologic agents. So to say it is an uncommon feature of VKH, duration of presentation and development of retinal vascularization can happen in between 6 months to 1 year. The cause of proliferative retinopathy in VKH is probably because of long duration of either treatment discontinuation or suboptimal dosage. My conclusion is proliferative retinopathy is an uncommon feature of VKH in patients with suboptimal control of their inflammation. Proper uveitis management is very essential to cause regression of this retinal neovascularization. Thank you.
Hold on to the last slide only. Patients are non-diabetic.
10 years, sir.
Diabetic.
From past 10 years, he was not controlled, already on insulin.
It's very, very confusing presentation. Very, very confusing presentation. But I think ultimately it was VKH. When VKH requires, this picture is typical for VKH. And VKH requires treatment for years and years.
Yeah.
Years and years on immunosuppressives, and it's not 6
So
months.
one thing why I excluded VKH, because he was surgically operated. That is one of the criteria we say there should be no previous history of surgery or an ocular penetrating trauma. So though I knew it looked like VKH, but still I couldn't put into it because there was a recent history for 1 month back.
And VKH is one disease where steroids will not work fantastically.
Yeah, and in spite of putting him on azathioprine and MMF, he was still deteriorating. He developed inflammatory CNVM, he developed anterior granulomatous uveitis, so he's moved on to biologics.
You see, VKH can, because VKH ultimately is a choroidal disease, it can develop CNVM. That's not a very big issue. And you have tackled very correctly, but only thing is, we started with laser and diabetic retinopathy.
That's because I could only see SHH with an NVD in one eye and the other eye had NVE. So I thought it was a simple PDR. So we started with treating it as a PDR, but
so
it
in retrospect, do you think that it was proliferative retinopathy or proliferative diabetic retinopathy?
It is a proliferative, I think to start with it was a proliferative retinopathy of a VKH case which I have misdiagnosed as a PDR. So I just wanted to enlighten that cases like this can happen.
You should label this patient now as VKH in a diabetic patient. No?
Yes.
What do you say, so?
No, it's quite confusing. In your earlier picture where you saw the survivor and it didn't have any other signs of VKH.
No, there were no cells, no cells, no.
It might happen in diabetic
And he actually improved well post surgery also.
It might have, it can be a diabetic retinopathy and later on developed an episode of.
No, but the hemorrhage, these
No,
dot and dot
I think
hemorrhages.
Vivek Som has a point. In a patient who has a proven subhyaloid hemorrhage with PDR, he may have developed VKH.
Yeah, but there are case reports where there is.
Did you get his renal parameters done?
Yes, sir, the normal.
Because you see, a lot of patients with PDR, if you get some cystic swellings, uveal effusion is very well known in renal hypertension also. In a patient with renal hypertension, you see, you should get his kidneys evaluated very nicely.
Yeah, kidneys are all normal.
Yeah. But the OCT picture is typical. But I had one lady long time back where we published also that renal hypertension, having a picture like this. So I was going to ask you, but this fundus actually looks too good for renal hypertension.
But renal would also have multiple exudates.
Yeah, multiple.
After this. He had uncontrolled.
Those typical.
So at the end of it, you are still leaving us in a confused state of mind. That personally, I would agree. Normally, this kind of proliferation NVE we don't get in VKH. CNVM you definitely get, but this kind of NVE you don't get in VKH. Any opinion from anybody else? It's a PDR. It's a PDR primarily, where you can explain NVE. You can explain that large subhyaloid hemorrhage also with PDR, but
Autoimmune disorders are sometimes precipitated.
And he was all normal for.
So maybe you did laser and after that, that thing precipitated in the eye.
So laser was done in 2021 December, and he developed this in around March.
When did you give steroids?
March, July. The minute he developed, March 2022 is when he has developed the VKH picture.
3 months.
Yes. Sympathetic hypomia, I heard that. It can.
Vitiligo it can be present in them also, but how long? Probably I am not very sure that when a sympathetic ophthalmia will develop a vitiligo-like picture. The only differentiating point, as Madam has already mentioned, is presence.
After surgery, did the patient develop this kind of symptoms?
So the cataract was done in November in right eye, and vitrectomy was done in February 2022. And he developed it in March.
The history of vitiligo was there since
long
It
time.
was there since long time.
So therefore, what you were saying now that vitiligo is there, I think, for ages.
Yeah. This is his photograph from past 3 years old. It is his WhatsApp picture. That is when I asked him send me your actual picture, and he resent it.
Audiometry here. We still are confused actually what's going on, but worth presenting, and food for thought for everybody.
It was a very good presentation, and as always, the only thing I like to tell all the presenters that none of you gave the financial disclosures, which is very important for presentation nowadays. When you are presenting, you should give a financial disclosure. And the second thing is, all the cases were very nicely documented, and we had a very good discussion. It's always a pleasure to be with you, sir, and we always learn. Thank you. Thanks a lot.